This short paper is titled Clever, a Framework for Connecting Lived Experiences with Visualization of Electronic Records. And before I get into the details of the paper, I'd like to give a bit of context first. So the context in which this research takes place is very much driven by the application domain of population health management, and more specifically, given the recent shift in the UK and in other countries towards the idea of integrated care, where partnerships of organizations, including health organizations, local councils, community, and voluntary organizations, all work together in order to sustain and maintain the health of and well-being of a population. So really this shift towards integrated care planning has also given rise to the idea of whole systems integrated data sets, such as the connected Bradford data, for example, that holds linked and anonymized records for over 600,000 citizens, including their health, education, housing, all sorts of different routinely collected data. And so a couple of years ago, we set out on a mission really to try and understand the hidden role of visualization in this new way of working, and as institutions work together to redesign their decision-making workflows and seek to integrate more data and more visualization in these workflows. So in this presentation, I will highlight some of what we've learned from being immersed in this population health research setting and some of the reasons why we found a need for a systematic framework that can connect the soft intelligence that contributes to the process of decision making, or what is often referred to in population health as the lived experiences of the stakeholders within this decision-making ecosystem, and how we can connect those lived experiences with visualization. And then I'll talk about the preliminary framework that we're proposing in the paper and the implications that this kind of framework can have on our design philosophy as we approach designing new visualization tools. And then I'll wrap up with some next steps in order to iterate the framework. So starting with why a framework for connecting lived experiences with visualization, and I'll structure the argument around two main aims. One is representation, and the second is agency. So for representation, one key aim of our framework is to bridge what we felt is a representation gap of decision makers in the VIS literature. And this lack of representation really dates back to the very definition of the design study methodology, as the seminal work by Sedlmeier et al. Defined a number of stakeholder roles that were deemed interesting and worthy of building collaborations with by VIS researchers. And these roles included people like frontline analysts, the gatekeepers, co-authors, and fellow tool builders, but the word decision makers really is nowhere to be found in these roles. And we've seen the impact that this lack of representation has on the way we define users' tasks in this critical reflection paper by Demara and Stasko last year, where they highlighted the missingness of decision-making as a task in most existing taxonomies in the VIS literature. We've also experienced firsthand the implications that this lack of representation has on the utility of VIS software. As we ran an interview study last year, in part of our study, we explored the role that recently commissioned visualization software had in an integrated care planning setting. And when we interviewed the data people, they shared some very positive attitudes towards this new exciting data tool. But when we spoke to the district level decision makers, their perspective was a lot less enthusiastic. So they were saying things like, it doesn't tell me much, doesn't take into account the demographics or employment or housing or anything. And our findings are very much in line with what Demara et al. Reported in this 2021 paper, where they highlighted that one of the key differences between decision makers and data analysts is that decision makers rely more on qualitative data sources, which they need to be integrated with data analytics results within a single interface. So the first aim of the Clever framework is to help us researchers to represent and systematically map decision makers' processes and the soft intelligence that supports these processes. But the disparity of this soft intelligence also means that there is little agency in population health decision-making settings, where there is a strong sense that really no one owns the full picture and that there is no single version of truth. This is very well captured in this quote from a co-design workshop we ran a couple of years ago with district-level decision makers, where they said that the dream is to be able to look at the pathways through services from the perspective of a child going through the journey rather than an outside perspective. So this brings the question of how to incorporate the disparate nature of these different views and the different lived experiences of the people who really own the narrative and own the story into the data visualization tools. And would something like the brilliant data hunches work by Lin et al. Work in a setting like this? Unless we know who has a focused understanding of routinely collected data and how much of a mismatch there is between data and the lived experiences of the people represented in those data, the answer is very likely going to be no. We need a new way to approach this problem space. And so, to elaborate on the second aim of the Clever framework is really to improve decision makers' agency by explicitly capturing the levels of information ownership and centralization across the different decision making contexts. So our preliminary Clever framework sought to address these two aims by first of all identifying the stages of decision making, going from the two high-level stages which start with capitalizing on one's tacit understanding of people and situations, to synthesizing relationships to build rules that underpin decision making. Now, these human processes take place in different decision-making contexts with varying levels of information centralization and agency, starting with the very low centralization in district-wide settings to the more localized context of clinical decision-making. So we started to look into what constitutes a domain model of the actual processes taken by these decision makers as they integrate bits of data with bits of soft intelligence to make decisions, and what types of soft intelligence can be expected to propagate across the different layers of the decision making system, starting with the community's lived experiences and how these lived experiences get handled and considered in the different contexts of decision making. Here's a concrete example to help explain and operationalize the framework. This is a case study where the connected Bradford dataset was expected to help district-level decision makers plan better connected services for a population of neurodivergent children in Bradford. The first mission for population health decision makers is to identify the so-called reference population. This is the group of people who can essentially benefit from an intervention. To build our domain model, we started by looking at ways in which this concept can manifest in data. The traditional way of looking at data would tell us that this is a mapping between a set of data references R, which can represent, for example, people in a given locality, and a set of characteristics C that map members of the population to relevant features, such as ethnicity or events such as diagnosis. So we looked at two relevant diagnostic codes to identify children with developmental disorder of motor function and autism spectrum disorder, and we were quite surprised to find that out of 600,000 people in connected Bradford, only 154 had a diagnostic code for DDMF. Now, immediately this was captured by our domain experts, as they said they would expect this number to be at least 5 times as high as the number of ASD children in the district. Now, this data hunch was quite useful to identify discrepancies in the data, but it doesn't necessarily inform decision makers who want to understand the real journey of these young people and where interventions can be most effective to improve their experiences and their outcomes. So we expanded the data model to include explicit domain knowledge represented as R epsilon and C epsilon. These knowledge constructs can be mapped to traits captured from the data or simply narratives that complement data. Now, such narratives can include other clinical codes that can reflect diverse data entry practices across different organizations, or clinical guidelines about risk factors to consider, other data sources that may have been missed. For example, some services were found to keep data about their cohorts in a separate patient tracking list, while they waited for a diagnosis, or some information about known inequalities in certain localities where there are several barriers to accessing services. So all these types of soft knowledge could be captured within this explicit knowledge representation in our model. Each of these real-world narratives bears a certain level of computational relevance, which we define as a measure to connect those lived experiences with data. This can be calculated in different ways, and we'll look at one example shortly. The other measure we define for utilizing this concept reflects how relevant a specific characteristic or event is from a lived experience perspective. So one can regard these two measures as complementary to one another, where one tells us how much data can tell us about this particular event or characteristic, and the other reflects how much people care about it. Now, this leads us to a design philosophy which we're advocating through the CLEVER framework, and that is that the real world is not data-centric. We developed an early prototype to exemplify this design philosophy, where the main screen of a visualization dashboard has more to do with what people told us and less to do with data. Starting with an overview of the scattered context of care, for example, young people with ASD may have encountered. The rows in this matrix represent these contexts of care, even the ones for which there is very limited data or no data at all. The columns then represent what factors the decision makers within these contexts would consider to build their understanding of the situations that this cohort encounters. Now, these may, for example, include conversations between the parents of these young people and their GP about speech and language issues or social behaviors. But discussing one or more of these traits may or may not mean someone will eventually end up with an ASD diagnosis. However, a needs-based approach for service commissioning and planning can perhaps sufficiently be informed by the relevance of these traits. And in order to show this kind of relevance, both from a data perspective and a lived experience perspective, one can show very simple sort of computational relevance measure. In this case, we showed the prevalence in a population as a computational relevance measure, and then we showed a relevance measure based on the qualitative data that was collected through primarily focus group discussions with parents of these young people. We also show the overlaps across the different contexts to reveal the relevance of a trait to other contexts. And now once this human sort of perspective is understood, one can then expand their view to start looking at some data dashboards and really understanding and digging deeper into the details of how this data is recorded and then how it's sort of coding practices change over time and what demographics exist. So really delving deeper into the data side of the story can be done within these embedded dashboards. The next knowledge construct that the CLEVER framework allows us to capture and externalize is people's understanding of care pathways. And these are typically manifested in things like clinical referrals and waiting lists, but there are several pieces of information that could potentially influence the way data and soft intelligence are collected to map these pathways. We represent these pathways at two levels of localization and information centralization, the within clinical services level and the cross-service care pathway level. The details of both are elaborated in the paper. One could represent the cross-service pathway in the form of a Sankey diagram with line thickness representing the flow of people across the different services. And within each service, we have mixed between using embedded dashboards, and in some cases we used Nadia Bremer's storytelling with chord diagram as a way to mix narrative with data. Finally, our next steps will build on our existing methodology in which we undertook a number of steps to develop this initial framework, and the dashed parts here are left for our next steps to iterate the framework. Specifically, we are keen to undertake a series of deep dives to explore the role of visualization in externalizing and organizing the communication of domain knowledge across different stakeholders in a VIS-assisted decision-making ecosystem. Our literature review so far has revealed that the dashed lines in this flow is where VIS research is currently lacking. For example, where there are some brilliant solutions to visualize data and analytic provenance between VIS designers and data analysts, it is not exactly known how much of this information can and should be communicated to decision makers through visualization, and how VIS can support the capturing and communication of communities' lived experiences and the process by which decisions come to be. Identifying the role of VIS will also enable us to study the design space for knowledge externalization in ways to balance between narrative and data, not for journalistic purposes, as is traditionally the most important use of storytelling with data, but to really create a common visual language between the stakeholders of population health decision making.